I'm very excited that we have Anna Gray here again to share with us for Fidelity and Measuring the Impact 201. And we have introduced Anna a few times already, but I wanted to check in and see, Anna, would you like to say anything else or more about yourself before you hop in?
No, just it's great to be with y'all, and I really appreciate all the work you all do. So just thank y'all. Pretty exciting stuff.
Well, we're so excited that you're here. As a reminder, Anna is with Prosumers International and has been in our workforce for quite a while, helping to lead and make some of the big impact from early on and through now, still making a lot of big impacts in our field. So Anna, whenever you're ready, if you want to share slides or start out without slides, it's up to you and feel free to go for it.
Okay. Well, first, just again, it's really great to be with you all. And just to let y'all know, this is a big topic. So I am going to do my best to give you enough information for you to find the information you need. And so I'm not going to endorse particular ways of evaluating the impact of your programs, but I am hopefully going to give you enough information that you can do some searches on your own and find what works for you. And it depends on how deep you want to get into it or not. But we're going to be talking today about how do we true ourselves up to Fidelity, what we look at. And we've covered that some, so I'm not going to go as much into that as I am how do we begin to measure what we do. All right, so we're going to jump into it. Oh, the other thing is I'm depending on y'all's knowledge. I am not by any means an expert. I chose not to be a psychometrician for a lot of reasons. And I may throw Julie under the bus because she may know a heck of a lot more in terms of surveying, developing surveys. And in fact, we will be reviewing a survey that Julie's a co-author of. So this is a conversation. It's not that I'm an expert. It's as much that we are all experts in what we do. And we're discussing the idea of how do we, the nuts and bolts, how do we show what it is we do. So we're going to jump right in. All right. So, and some of this may be a brief review from last time. What is fidelity? The quality of state of being faithful or loyal. What are we being faithful or loyal to? What are we truing ourselves up to? And how are we, what are the instruments that are available now for us to use? And how do we use them? So one of the things to be aware of, if we don't know what we stand for, if we don't know what our standards are, if we don't know what our values are, we will most likely lose our focus. And that's in the best of worlds, we'd lose our focus. We could completely lose our way. It can lead to mission creep. And given our current environment that we're working in, we run the risk of becoming more and more clinical because there is so much pushing us to do that, which is, you know, one of the key components of peer services is that we're not clinical. So it's for us to be aware that if we're not, if we don't have a North Star that we can true ourselves up to, we will run the risk of soon not being a peer-run program, even though people with lived experience may be the ones directing it. And just because we have lived experience does not ensure fidelity. So that's something for us to keep in mind. We are peer-run organizations for a purpose. This requires fidelity to values and standards. All right. So just a quick review. The standards of the CAPRAS. CAPRAS is an accreditation process for RCOs, recovery community organizations. They have 7 main principles under which they have a lot of various standards. Recovery principles, culture, and climate is one of the things that they assess. Ethical framework for service delivery. What are the ethics upon which you develop and deliver the recovery journey support you have? Peer leader development, peer supervisor development, governance and program oversight, management systems, and peer support capacity core competencies. So peer support capacity is maybe the 7th thing, but if we're not providing peer support, all the others don't matter. So it's important for us to keep that in mind. It is the foundation, not the afterthought. And on many of these approaches, it is a key component, and sometimes it looks like it is playing second fiddle to management systems and governance, because those have been in use for a very long time. We borrow from existing models in the business arena, in the nonprofit business arena, that may not be peer-led. So it's important that we know that what sets us apart is we're providing peer support. And if we are not providing effective and good peer support, then we're not providing peer-run organizations. We're providing an organization that may do a lot of really good work, but I would assert it tends to develop the outcomes that are seen in existing standard clinical settings, and we are not that. So one of the things to keep in mind, that is a priority. You can find, so these are hot links. It should create a hot link even in the PDF so that you can go to the CAPRAS website. When you go to the CAPRAS website, there is a place where you can actually pull down the manual for accreditation. My recommendation is that you do that. It costs money to get accredited. It costs, last I heard from CAPRAS, depending on the size of the organization, anywhere from like $7,000 to $12,000. And it may have gone up since then because that's been a few years. One of the things to consider is, even if you may not be going towards accreditation, you can live up to the standards. You can download the manual and you can do the work to be in alignment with the standards, even though you may not be going for the accreditation. So as we look at asking for more money to be invested in us going through an accreditation process, or being able to demonstrate that we meet our own model standards, serves 2 purposes. One, we don't have exterior organizations telling us who we should be and what we should look like, and we can reduce the risk of those funders who want to invest in us, because they know that we have oversight, we have standards that we meet, and that we are in fact doing what we say we're going to do. So there's a lot of good reasons to become accredited, and you can do all the work to be accredited without paying the money. And then when you do have the money, become accredited. This is, unfortunately, we're playing in an arena that asks us to take on the same trappings of a business model, of a healthcare model, and accreditation is part of that model. So even though taking on these things is a slippery slope, if we're careful, we can show them that we are quality services without taking on their view of human beings and what recovery is, because we see recovery differently than clinical settings. They tend to see it as maintenance and stability, especially on the mental health side, and neither one of those things equal thriving in life. And on the substance use side, there's a lot of focus still on abstinence in treatment settings, even though they're beginning to talk about harm reduction. And abstinence is not thriving. It could be a component of thriving that may be someone's choice for their recovery, but it does not, in and of itself, mean that you're thriving in life, which is how I see what we're talking about in terms of recovery, even if you use the SAMHSA definition of recovery. So these are some of the things to consider. Again, I invite you to go to their website, download the manual. They have a pre-accreditation survey on there as well. It's a good tool for you to talk with your team and say, where are we on this? The more honest you are with yourself, the better results you're going to have in terms of fidelity. So these are some of the things to consider. All right, for the mental health organizations, we have the FACET. Currently, the standards of the FACET are in place. So they're outdated. There needs to be more work. Prosumers International is actually developing an accreditation process, but it is in process. But it includes, the FACET includes 6 areas: operating structure, environment. Is it trauma informed? Is it an environment that is conducive to recovery, especially mental health recovery? Belief systems. It's tied into, do you believe that recovery is possible for everyone? And our belief systems around people's capacity. Peer support, again, if it isn't peer support as we define it and know it, then it's not a peer-run organization. So that's a key component in the FACET. Education, what efforts are made to grow leadership and to grow the participants in the program. On the mental health side, there's a lot of emphasis on that horizontal management structure, where people who are part and parcel of the organization also provide input and direct the kinds of services that are provided. And then the advocacy component. How do we advocate for our rights, for services, for funding, and for a recovery model of service? So these are the components that we see on the mental health side. So right now there isn't a standardized accreditation process. Again, we're in the process of building that. In the meantime, there is literature available that can help you start building the infrastructure and the fidelity, so that when we have the accreditation ready to go, you can be accredited fairly quickly and easily. So that's where we are with the mental health piece. Also, another thing that's important, and I really focused on us providing peer support as peer support. And one of the places to look for, are we really providing peer support as peer support, is in the National Practice Guidelines of the National Association of Peer Supporters. I encourage you, if you have not read this document, in terms of the everyday nuts and bolts of how you do work, this document can be extremely supportive in that. And it is our best effort to quantify, if you will, or to at least define or say what it looks like when we're doing peer support. And this is this is a tool that's good to help us avoid mission creep if we're going outside of the values presented. And so each of the values is broken down in this document by what it is that a peer supporter does under that value in terms of direct services, if you would. I'm using systems language. I ask forgiveness for that. it is a good shortcut, but we're talking about walking along with somebody on their recovery journey. It's not that we know more than they do. It's that we're both on this track together, and we may know where some of the potholes are, but they may know where some of the, they may know some of the shortcuts. So we're learning together. It isn't that there is an expert or a helper and a helpee, but in that mutuality, walking on the journey. And our systems language, the whole idea of services provided, and we provide services, and who we provide services to, is totally power differential language. And so please be aware, we're walking along with them. And yes, they come into our organizations seeking that support in walking on that journey. And so that's the context in which the values and activities in the National Practice Guidelines are presented. And so when we're talking about fidelity, we've talked about standards, we've talked about ethics, in that ethics are part of the CAPRA system for sure. And now we're looking at values. And if you do a search, like you can go on, just for grins, on ChatGPT and put in what are recovery values for mental health and substance use, and it loves doing things in 10-point bullets, but yet you will find that there are some core values, and then it varies according to state, if there's values that states have in their accreditations process, things like that. So but these are the ones that are standardized in the National Practice Guidelines. And then I encourage you to look at what are the values that you as an organization may have, the values that your community has, and find how you live up to your values and peer support. So there isn't a set recovery values. This is the closest we have to a standardized group, and there are others out there that are important for us. Self-determination being one of them. So be aware of that. All right. I see. And Jesse, I think you're checking the chat for me. I see there's a lot of chat going on.
Yep, it's mostly me just adding the links from your slides into the chat box.
Awesome. Thank you. All right. So I just wanted to make sure I wasn't skipping over some questions. And the other thing, this particular document not only has the guidelines for peers, but then it has the supervisory approaches that support those guidelines. So it's really great for your supervisors who are supervising peers to have that approach that is going to encourage fidelity to the values. So this particular document combines both. You can find it on the NAP's website, and again, this is a hot link that goes right to it for you. All right. The other is SAMHSA's core competencies for peer supporters. Some of the things that we're truing ourselves up to is that it's recovery-oriented, person-centered, voluntary, relationship-focused, and trauma-informed. You can see some of these terms tend to be part of the clinical setting as well. Person-centered. Peer definition of person-centered is somewhat different from the systems definition of person-centered. As I've seen person-centered implemented in treatment settings, it's like, yeah, we'll ask the person what they want out of treatment or what kind of treatment they want. They don't ask them, what do you want for life and how can we help you get there? And those are two very different approaches. And even if they do say, what do you want for life and how can we help you get there? They will still tend to influence you could call it coerce you into taking the services they provide, and they provide a set of services. So person-centered still is, it is not truly, hey, what do you want? What do we do? How do we get there? Where are the resources? Let's go discover this together and learn together, which is the relationship focused. And it's all voluntary, and it's non-coerced, which are is the opposite of voluntary, right? So these are some of the things to consider. All right. So much for Fidelity. Any questions about Fidelity? Y'all got this? You know where to find everything? You can't wait to get out there and look at and survey your own organization?
We've got heads nodding yes and a couple of thumbs ups.
All right.
Oh,
I have a not a question about Fidelity, just more of a I guess a statement. As you had mentioned, Anna, with the CAPRAS. I remember when I was working at Communities for Recovery and we went through the CAPRAS accreditation. It was lengthy and it seemed like a lot at first, but I love what you mentioned, and I'm sure this goes with all accreditations and things of this nature. But as a team, I remember breaking it up into sections, the sections that they had, or the sections, because those are just, you put up the 7 or 8 main sections, but then each section broke into 5, and then those sections broke into 3, and there were just questions upon questions. But what we noticed and what came about the accreditation was a lot of holes that we didn't know that we had, right? So we thought we were, our intentions were having of the Fidelity model, but through the process, we realized that we were missing a few things, statements, all sorts of things. And as I mentioned, it took 8-10 months. I can't remember exactly what it was, but our team got stronger. We filled some holes in the gaps that we didn't know we had. We communicated better with each other. Like, it was just all these pluses. And then of course the overarching goal was we completed it, we got accredited, and then I think we got a pretty good score. And so it was just a whole process. It was a lengthy one. It was important to us. At times it was challenging and a little, we were like, how did we not know that we didn't have this? But that was okay. It was totally okay. And so I just wanted to share that with everyone because it was something that I thought was in place. But again, as we get into our roles, wherever organization that you're in, we or your team has more oversight to change these things and to find them and to fill them. So
thank you for bringing that up, Javi, because I think one of the other things is we can approach accreditation like we did exams in school. I'm gonna fail, I'm gonna pass. In piloting what we're doing with the facet right now, the teams we've interviewed, it's really funny because they're really like into the interview and they answer and then at the end they go, did we pass? So accreditation can feel like you're being evaluated and assessed and for a grade. And in fact, what it is we have a set of standards. Where are you and what can you do to get there? It isn't a judgment. And that any accreditation system, CAPRAS or the one we're developing, or for that matter, 𝐏𝐫𝐞, or all the ones that are out there, it's like you either get the certificate or you don't. That doesn't mean that you have to stop what you're doing. It just means you're not one of these animals, you're a different animal. So if we look at this as an opportunity for growth, it's amazing in terms of building the team, like Javi said. It also, one of the biggest challenges we have, because sometimes we have turnover, builds the culture. And if you can build your culture for your organization, then people coming in get acculturated to it, as opposed to you constantly trying to figure out, how do I keep my culture? Because you will have a core team that's gone through this together and have now words and concepts that they can, that build the culture for them, instead of this thing you can't quite put your hands around. So it helps operationalize that and makes it easier to maintain the culture of recovery you want, and have people learn that culture when they come in. So these are some of the things that it actually serves a lot of purposes. And you can go through it and not have some oversight from somebody else, because you have access to the tools to look and see, do you measure up? So something to consider. All right. Any other comments or questions about Fidelity? It is a process. It's a good idea to have, depending on how big your staff is, but if you have 1 or 2 people who revisit this every now and then, so that you can look and see, hey, you know, we all jumped in and created values for the organization, or we created our ethics just for our organization. Have we looked at them in a while? Is it time to maybe just bring them up in staff meetings? Say, hey, by the way, have we reviewed our organizational ethics? Have we reviewed our particular means of reaching these standards, just to keep us on track? And when you have a couple of folks who do that, maybe even somebody who is a staff member and a couple of folks that you provide services to as a subcommittee that reviews this, you know, every 6 months, how are we doing? It will help you stay on track. It keeps that culture in place, and it keeps you centered on, we're doing what we say we're doing. So
I have a question. I'm sorry.
yeah, go ahead, Elaine.
I can't find my hand to raise. That's weird. But
That's
anyway,
okay.
So the CAPRIS thing, first of all, I didn't know it cost so much. I do remember being there when CAPRIS came, and it's interesting to have this different perspective than Javi did, because I wasn't in the middle of it like that. One thing I'm curious about, though, so once you get certified and with this big amount of money, is this something, and I'm not in the office to even know enough, like, is this something that is continuously revisited in terms of paying, having them visit? And like CAPRIS did come and visit us. I totally remember that. So do they come every time? Just kind of curious what that looks like, or is it like a one and done, like, yes, this is what it's supposed to look like?
So an accreditation process means that the accrediting body is basically giving their word that you meet a certain standard. And so they do come back, and it has to be done every so often. And I am, for the life of me, not remembering how often CAPRIS comes back. I want to say 3 years. Javi, do you know?
It depends. It depends. So they have a 3-tier grading system where I can't remember the exact where the cutoff points, but if you get, like, let's just say a C or below, then they have to come back, I think, 2 years. If you get between a 70 and a 90, then it's 3 or 4. The max is 5. So I know, like, if you got like an A or whatever, that they would come back 5 years. And that's the cutoff point. So but I remember it was a tier type thing. So I'm almost, if not sure, it's in that 5-year. Y'all should be getting one
Maybe
soon.
that's why we haven't seen them.
Yes.
Okay.
Yeah.
Okay, that's why I even had that question. Thank you
It's a
so
great
much.
question. Great question.
It is a great question. The way we're building it around for the mental health folks is we've got a 3-tiered. The first tier actually doesn't get accredited, but is acknowledged as working towards accreditation. And that's our evolving organization. And then we have established organization tier, which is the people who've been working it, and may not quite meet all the standards at the highest level. And then we have a center of excellence, which is those who meet those standards at the highest level. And centers of excellence would probably not need to go through the whole, again, this is in progress, through the whole process, except for every 3 years. An established organization would go through the process once a year. And then the evolving organization would get continuous support and technical assistance for 12 months. So they can meet that first level. And for the organizations that have to do the process every year, it would probably be like 2 years of a paper review, not the full process, maybe a couple of interviews with people and a paper review, and then the third time go through the whole process again. So those are the things we're looking for.
Now, if
Right now.
you're a new organization and they would help you like for 12 months and stuff, which sounds fantastic, by the way, but you would be paying for the accreditation to get that service to begin with for them.
Right. The intent would be that at the 12 months,
Mhm.
you would be ready for accreditation. And it would be negotiated what that would look like and how much it would cost, depending on how far the organization has gone. The intent is, on the mental health side, we don't have as many organizations. And the intent is to grow new organizations with the standards in place from the get-go. So they're not having to unlearn before they can get there.
That's awesome. Thank you.
Yeah. Any other questions? So, measuring impact. How do you know you're getting the job done? What is it we're measuring? How do we show others that we're actually yielding the results we say we have? We are peer supporters. Peer supporters are the flavor of the month. Everybody wants one. Where we've started out in our own little gatherings, informal gatherings, supporting each other, and we did well. Others noticed. Eventually, it got formalized, and we now have certification processes. It's like we have been growing. I say the flavor of the month, I think we're here to stay just because we're honoring and we know what works. And right now, we're being seen as adjuncts to the system that can, and in some ways also, unfortunately, cheaper labor to get work done in the system. And so there may come a point in time when our interests no longer fit the system's interest, and we may have to do some advocacy work to show that we are professionals, we deserve professional salaries, and we do what we do, not what they want us to do. And that may cause a little friction, so we may not be as popular 5 years from now, who knows? If we do this right and we do the advocacy right and we do this piece right, we show we make a difference. We show we save the money, not because they pay us less, but because people get their lives and take off and aren't using all their services. Then we will be able to ensure that our profession continues doing what it is we say we do. Now, the challenge here is that things may look a little different on the substance use side than it does on the mental health side. Because on the substance use side, the entities providing most of the services are private entities, so they want warm bodies in their beds because that's how they make money. On the mental health side, it's mainly public mental health, and a lot of and the way it's structured, people end up on waiting lists. So there isn't that fear that if somebody actually does well and goes on, we're going to lose money because they have somebody waiting in the wings to come fill that slot. So how we do the advocacy may be a little different. The messaging may be a little different on both sides, but we definitely have the ability to ensure not only fidelity in our organizations, but fidelity of our profession moving forward. Any questions about that? Okay. And what's going to be important is for us to continue working together to find those messages, because the system keeps pushing us together. And if we're at odds with each other on our message, then we will cancel each other out. If we find a way where we can say, for mental health, this is the message, for substance use, this is the message, and the overlap is that people get their lives and have amazing lives, and we save money. And we find a way to do that both in a for-profit world as well as a not-for-profit world, and where the demand for effective services increases to the point that when people do better, organizations who are for-profit do better because people want to come there. So these are some of the things we need to think through as leaders. And I encourage you to start thinking maybe even at those levels, if it's something that you're interested in. So how do we show we do what we do? What do y'all think?
Data?
Okay. Data. Yes. I'm going to actually get this where I can share it and type on it at the same time. Again, I said this might look a little clunky, but I think it's great if we can do this. All right. So y'all become part of the PowerPoint. So data. All right. So where do we get data from?
From our peers, from our participants.
Okay. Say more.
I'm sorry.
Say more about that.
Oh, yes. Yeah, we're engaging with them. We're I don't know, we're collecting their information. I know at our organization we use Recovery Link, and we use BART 10 scores to see if they've moved up during the week or they've went down. And then at the end, usually at the end of our sessions, I would like, hey, your score moved up a little bit this week. You know, you want to talk about it? What was different for you? What worked, what didn't? I don't know if that's what you were looking for, but
Yeah, I'm just curious what y'all are using. So weekly scores on
yeah, we call them
these-
BART 10s, brief assessment of recovery capital.
All right. Chris?
Thanks. So, you know, one of the things that we try to do is collect qualitative and quantitative data. So we deal with self-report. If the person that we're working with is reporting that they've made some positive changes in their own lives, that they detect that they're seeing progress, we take track of that. I think the secondary component that we look at are we have a few different metrics that we've utilized in harm reduction and peer recovery support contexts. The first one is a PHQ-9 index, which helps to assess whether or not a person is experiencing some depression. We do that every 30 days, usually after they've engaged with services. The second component is we have a short survey that gauges anxiety called an OASIS. Neither of these are, I think, really adequate tools, but they do help. And the third component is we work with what's called a recovery assessment scale, or a RAS. That gauges a person's preference or attitudes towards recovery. What we have seen is a correlation and an inverse relationship between attitudes towards recovery and depression and anxiety. So as a person, as their depression and anxiety tends to fall off, by and large, we tend to see attitudes towards recovery improve. If we see the attitudes fall along with the depression and anxiety rising, we know that there may be something going on that we can engage them with, and maybe, hopefully if we have the rapport built, we can start to work on some of those issues. The third element that we utilize in terms of harm reduction is called an Atlas software, and we work on a few different domains. We track, we get a baseline on their primary health, like what sorts of primary health problems they may be encountering. Do they have, diabetes? Are they dealing with Hep C, HIV, anything of that nature? We track their any behavioral health challenges they may be experiencing. I hate to say, carry a diagnosis in those terms, but anything that they may report that they've been struggling with that we might be able to help. We also look at their last, if there is an overdose, when their last overdose occurred, where it occurred. We look at, that helps us to generate hotspots where we can kind of concentrate our outreach efforts. And then we also look at tracking how they're gaining their income. So are they out there, are they dealing, or are they established in a legitimate income stream? Do they have any income? That helps us in relationship with the BARC 10, which is recovery supports, and helping them engage in recovery capital. The other thing it shows is the impact of the program that we have. As individuals maybe are able to avail themselves of things like Social Security, disability, or maybe they re-enter the workforce, so they're able to pick up some work. We also track whether or not they're doing any volunteer work, anything of that nature. But that gives us an idea of the impacts that our program has. I hate to think about outcomes in terms of the people that we serve, because in some level, like if there's like a bad outcome or something of that nature, I tend to think it's something that the program maybe not be may not be leveraging, rather than, in common parlance. I think sometimes we tend to hear people say, well, maybe they weren't ready or something of that nature. It might be the program needs to leverage something too. So it gives us an idea of how we can improve our quality.
So based on what you just said, Chris, on the mental health side, that is when services are provided and the outcomes are not that were expected are not gained, we are called treatment resistant. Like somehow or another, we intentionally push back on the treatment. And one of the things that, in terms of flipping that message, is that it's systems failure.
Yes, I agree with that 100%.
So those are some of the things that we also are looking at in terms of advocacy, and in terms of not as a judgment, but as a way of addressing questions that are coming up in the system around why, we say we're recovery based, why aren't we getting the results? And
Right.
so for systems who are really looking into that, it's an opportunity to say, and it could be that it's a Venn diagram. It may be that the person has some personal barriers to achieving their goals, but looking at also what are the systemic barriers. So yeah, thanks for bringing that up. Elaine?
Yeah. We're actually on the recovery data platform by Faces and Voices, which is fairly new. But what I have noticed, and I'm not knowing a lot about that platform, but I have noticed it is continuously evolving. Since it is newer, they are working with us. So we're able to hone in more on what we want to capture. I've noticed that. But as a peer specialist, when I'm trying to see like my impact or whatever, the impact our organization makes, I love this. And this is really sounds funny after Chris's very in-depth answer. But for us, I mean, we do bark tents and stuff like that. But for us, and this really comes from my supervisor, we're looking at goals, goal completion, you know, those kind of things that for that one-on-one engagement, especially since everybody's recovery or journey is different. It's about their goals. So that is something that we do capture, is whether or not they are able to complete those kind of things.
Awesome. Thank you for that, Elaine. Anybody else want to share? Okay, so
Can you hear me, Anna?
I don't know if they can hear you. I can hear you. Sorry, Janet and I are in the same room, so we're trying to make it work here. She said Form N, which is a it mainly is, you know, how many people were served, in what kind of setting were they served, if advocacy's been done, if it's group or individual. It's mainly counting things. So it is a.
Well, we do that, and then we have the survey.
Can y'all hear Janet? She said that we do this, and then we have a survey we do, which is the ROSA,
𝐻.
which was developed by from 𝐻𝐝𝐻. And then there's actually another survey that has an acronym that I never can remember the name of. P something or another. That we're using, which was also developed by and further developed by the team that we're currently using as well. Any that is geared, that other one's geared specifically towards COSPs or mental health peer run programs. Anything else that y'all can think of? All right. Well, this is a pretty good list.
I think there was a few things in the chat, Anna. Julie had mentioned Prios, and Elaine
That's it.
mentioned Columbus or CMBHS or Symbus. I know it's said multiple different ways.
Yeah, so Columbus is a state, it's a state system for reporting services. And it is used by people who contract with the state for services. And it is pretty comprehensive. It tracks demographics, it tracks service delivery, and is pretty comprehensive. I don't know, and having correct me if you're wrong, are there peer run programs entering information into Columbus?
Yes.
Okay.
The RSS programs enter information into CMBHS as they see fit. And it just depends. That's definitely a policy and procedure from organization to organization, but I believe all the organizations that get recovery support services dollars do enter CMBHS.
So it's CH.
CMBHS. It's clinical behavior, behavioral health.
Management is clinical management.
Oh, that's
And
right.
behavioral
Yeah.
health services, yeah.
Yeah,
Yeah, we
for
use
behavioral-
CMBHS
For behavioral health.
for Enreach.
I'm sorry.
Yeah, the CMBHS has, the BARC, they have an assessment of recovery capital, they have a recovery plan on there, an engagement status form. So, yeah, we use that for our Enreach program here.
Great. A few, right? Now, there aren't any on here. I know that the family partner organization isn't represented here. There isn't any that I know of that the family partners are using, except that are in the LMHAs at this time. So they're using whatever assessment tools, the CANs for kids, and that is information then that they use. But in terms of for standalone peer run programs for family partners,
Oh, I gotta get out of here.
there
dang it.
aren't some things that are
Okay,
that
Christine.
they're using. So and my comments that are coming up next are going to, I think, highlight some of the differences between the RSS and recovery communities or even the difference between RSS funded programs and recovery communities, and then the peer operated service programs, which are the mental health communities. And part of this is, I just want to say, this is not in any way to say that any of the things that are being used or that there's any concerns there, except for if you are in a fully peer-driven program, some of these assessments would not be used. So let's look at some of the challenges. So many of the assessments y'all just mentioned are clinical assessments. We actually have an ethical standard that's actually part of the Texas Administrative Code that says that peers do not do assessments. And so in our current systems, we are being asked to do assessments, and that is a direct violation of our ethical code. And when I bring that up, I usually get this, well, yeah, but no, it is in fact a violation of our ethical code. And most of the assessments that are being used are clinical assessments. And so these are some of the challenges we have, mainly because those are the assessments that we are being asked to do by the organizations we work in. And on the substance use side, so there's RSS programs that are inside of the clinical treatment settings. The RCOs, the standalone RCOs, may have a little more control over which ones of these approaches they take. Part of it may be tied to funding, which is a challenge. But if we look at peer support as like in isolation, in its purity of what it is, we don't do assessments because the people who we get to walk along with actually get to show up however they want to show up. One of the things we keep talking about a lot in our profession is that we meet people where they are. And we use that now as a buzzword without really paying attention to what it means. It means that every time we encounter that person, however they are is perfect. And it's not about are they further along or not. It's what are they saying is going on in their life, and are they saying they're achieving what they want. And so it puts us in a real quandary when it comes to the point of actually looking at, are we doing what we say we do? How do we collect that data in a way that is peer driven? And these are some of the challenges that we face as organizations when it comes time to measure and collect information that tells us whether or not we're doing what we say we're doing. And most of the instruments that we are using are developed by clinical staff and by clinical organizations. A lot of the ones that y'all mentioned were developed in clinical settings and use clinical language. There's also the other challenges when we're developing measures is that we have the system telling us what we should be using. For example, on the mental health side, one of the things that was really mentioned a lot is, do your services reduce hospitalization? Well, staying out of the hospital is definitely the goal of most of the people I've ever encountered. And for some, brief hospitalizations are part of their recovery journey. So it's not about, is the person getting their life? There's a lot of people who, because of the trauma they have experienced in hospitals, will do everything possible not to get caught and put in the hospital, regardless of what it is their needs are in the moment. And so reduced hospitalizations does not measure recovery. It measures what the system wants to measure, but it doesn't measure recovery at all. Length of sobriety is something that also gets measured. Does that mean that person is in recovery as we define recovery? I am not from that world, but in my interactions with substance use peer organizations and with people who have dealt with challenges around substance use, just about everybody I've encountered refer to some version of a dry drunk. The idea that just because you're not using doesn't mean you're in recovery. It doesn't mean that you have the skills to have an amazing life. And so those are the things that tend to get measured because they're easy to look at, but it doesn't measure, do we have an amazing life? For family partners, reduce in-school and out-of-school suspensions for kids who are dealing with challenges is what gets measured. That doesn't mean that child is learning. It doesn't mean that they are thriving in their family. It only means that, the school says they weren't a problem today, which is what the school is wanting to measure. So systems want us to measure things that are important to them. And for those that are around making money, a lot of times it's around how are they making money? Are they measuring those kinds of outcomes? It doesn't measure what we say we do as peer-run programs. So these are some of the challenges in how do we not assess, but get data and have information to be able to show that we're doing what we want to do. These are complex conversations, and one of the ways in which our professions have tried to strike a balance is in finding surveys and approaches that are developed by us, for us, driven by us, to be able to collect data. Because in the systems we navigate, at minimum, funders want to know, did you meet a metric? And the organizations we tend to work with or in have databases that we're required to put this information into. So these are some of the challenges. Any questions about that so far? Those are just the procedural challenges. Then there's other challenges like, what is recovery? How do you measure something that every human being defines personally? Right? When we say we're measuring recovery, it's what are we measuring? Right? Because each person gets to define that for themselves. So that's another challenge in us looking at, are we, can we say we're measuring the same thing for everybody? And recovery, when I say it's subjective environmentally and culturally, our level of satisfaction with our life is determined by our expectations. If we, and you hear stories of people who grew up in abject poverty, some in the rural area, you really see this contrast in rural areas versus city. There are folks who will say, as kids, I didn't know we were poor, because they grew up raising their own food, and pretty much self-sufficient, living off the land. My parents, my mother grew up in a rural area, my father grew up in the city, and their experience of the Great Depression was radically different, because the only thing that my mother's family bought was salt and pepper and other spices, and otherwise they grew all their food, and they bartered from their wheat crop and their food crop to get what they needed. They raised hogs, they raised cattle, they had meat on the table, they had food on the table, and didn't have any money. But my grandfather would take the wheat, get it milled into flour for an exchange of some of the flour to the mill. So never paid a penny. And then would barter, meat for spices. I mean, just never knew that there was a depression. My father, on the other hand, who grew up in town, the depression was devastating. So that you can see how environmentally and culturally their impression of whether or not they had something or didn't have something was determined by what it is that they felt like they had lost or couldn't get. And these are some of the things that, how do you put that into some measurement? Because it's based on what we expect ourselves to have. And wherever that bar is where our level of dissatisfaction is going to be if we're not meeting it. So again, recovery is that thriving, that level of satisfaction, the way we measure ourselves. The other thing is we're complex beings, and we evolve over time. Recovery, when you first enter into recovery, one of the measuring challenges is there's evidence that shows that when people first start recovery, their mental health goes down, especially on the substance use side. But there is a mourning period, a grief period for what all you've lost in being in your, in your substance or even being in your thought processes and behaviors that have kept you from thriving. So if you measure somebody at that time, are you going to say you're doing your job well or not? People are going to look on the outside and look, they're doing worse. Or is it that they're actually now beginning to confront what it is to live life and dare to believe they can have a life they love? Right? So again, we're complex human beings, and we're not linear, and we don't just assume, we don't just say, okay, I'm going to be better today, and then life is rosy. It doesn't work that way. One of the challenges is when we measure, we're measuring a point in time. And in order to measure points in time, we try to isolate things that can be counted. So when you looked at the things that are being used to assess us now, It's like suicidality. Let me reduce you into whether or not you're thinking about killing yourself. And Chris, I really appreciate that you're using that measure. My concern with that is the way that's being used in the standard system is every time I go to my doctor, my GP, I'm supposed to fill that out. My GP doesn't know I have a mental health background, and I don't want them to, because then they start treating what they think is wrong with me instead of what's actually going on in my body. And I don't know them well enough to tell them whether or not I'm having, urges not to be on the planet anymore. And so we've reduced it into a checklist that takes the humanity out of it. I'm not saying that's the way it's being used in a peer setting, but I will tell you, it does reduce us into, are you suicidal or not? And the kicker is, if you're lived in our world for very long, there's not too many weeks go by that I don't wish I wasn't on the planet. Does that mean I need an intervention? No. It means that sometimes it would be nice to tell the world to keep spinning and let me get off for a few moments. So one of the things that is a concern when we start looking at what are we going to measure is that we will measure what is measurable, and we will reduce ourselves into bits and pieces. And peer support is designed to respect the whole person. And recovery happens in fits and spurts. And sometimes we do great in our business life and can't keep our family life going at all. Sometimes it's one, the other, and sometimes the whole thing gets to working, but that's what we're striving for. Any questions in terms of the challenges we face when we're trying to answer the question, how do we show we do what we say we do? I will tell you, these challenges drive the team at Time H up a wall because we have these ongoing discussions. And sometimes let me just say that I am continuously impressed by their infinite patience with me because I bring up these arguments over and over again. Because these are the challenges in measuring recovery.
Great job.
So have I managed to upset any of y'all yet?
Great job.
Not at all. It goes along with the definition of really recovery. What is recovery?
So
I
at least-
want to add,
Yeah,
I
go
wanted to
ahead.
touch on that. We're learning as well, right? Recovery's self-defined. We had a participant who's he hasn't used cocaine for a long time. And then he said he wanted to celebrate, but he still drinks. So we had a team discussion. We're like, well, we should celebrate him. He hasn't done a substance that was causing him a lot of harm. Alcohol is not causing him to, mortgage his house or whatever, right? So it was an opportunity, I think, for us as a team to come together and say, well, let's celebrate him. This is a huge achievement in his life. So I think I feel great about it. So it's just something I wanted to share.
Thank you. I appreciate that. Yes, Angelina. Angelina.
Thank you. Either or. This is really like eye-opening. I think it's very difficult to measure these things because recovery looks different for everyone. Like it looks so different for you. It looks so different for me. It looks so different for Juan. Like we all have our own personal individual journey. So how you kind of put that in a box, that makes it so challenging. I just wanted to add that it makes it hard, right? Like it makes it super difficult. So this is just really, really eye-opening for me. I'm like, wow. Like I didn't know about the assessment thing. So when I first started doing peer support, I was working at another organization, and that's literally the definition of peer support there. Of course, it was a clinical environment. And so that's literally what we would do is we would do these assessments, like that was peer support there. And, you know, of course, this was at the beginning when I first started doing peer support before I even did the training. And once I did the peer support training, I was like, I can't even work here anymore because this is just not aligned with the values. So then I applied at Foreman and I started working here. But I think there's a lot of peers that don't have this particular knowledge about, you know, how we're not supposed to be, that's not peer support. I knew that it wasn't when I did the training, but you know, I'm more than sure that there's other people that are just kind of going along, going with the flow, you know, like, oh, well, it's a paying job and, you know, I've got to do what they ask me to do. And you really don't. Like, if it doesn't align with peer values, then you shouldn't even be doing it at all. And a lot of times I feel like people just are afraid to voice that, you know, and I did get a lot of pushback when I would kind of bring stuff up, you know, so, you know, it's just, all of this is just, it is super hard to measure when every individual is different.
Absolutely. Absolutely. Thank you for that, Angelina. And the kicker is we're still put in a position to have to show we're doing what we say we're going to do. If we want funded, you know, we can do whatever we want to without any oversight at all. If we're not using somebody else's money and we're not harming people, with a very loose definition of not harming people, right? But if we're going to say that we're fulfilling on the promise we are as peer support because we say recovery is possible, then yeah, somebody's looking over our shoulder. Yes, Chris.
I think there's, with that said, there's two pieces that came to mind for me. The first piece is room for advocacy at the national level with funders and not adjusting their expectations, but understanding really what peer support is. SAMHSA, for instance, and I mentioned this in the chat, has developed a definition of recovery through focus groups and things like that. Jesse mentioned that in itself has become jargon, and that's true. It's absolutely true. Recovery's become a piece of jargon. And a lot of that has to do with clinicians and their need to measure and codify everything, right? I think the second component is that there is a debate currently in peer groups about the nature of peer services and whether they're professional or paraprofessional. We do a lot more than just supporting clinicians, which is the paraprofessional element. We do a lot more than, we're not teachers' aides, we're not clinical aides. So that leaves the paraprofessional concept of that out. The question is the professional component of peer support and what that should look like, and whether or not we need to have developed funding streams and programs that are specific to that without the clinical metrics involved.
Yes, Chris, absolutely. And in fact, that I think the first step in that was House Bill 1486, in which it is put in state code that we don't do assessments. And it is put that part of the intent of having our own billing code under Medicaid was to say that you can pay for peer support as what peer support is. Have we sustained that message? I don't know. Have we made a lot of headway since we gained that billing code? We've got a raise, but it was a raise for the people who can use the billing code, not necessarily a raise for the people providing the services. So it's that we still have a lot of work to do, but we at least have some structures in place that we can use for advocacy purposes to have peer support stand on its own as a profession. So thank you so much for that, Chris. I really appreciate it. All right, so we're going to move on. So Jesse, I'm in a totally different time zone. How much more time do I have?
Just about 30 minutes.
All right, that's what I thought. I just wanted to double check. All right, so let's move on. Other ways that we use to look at this. And so we have the ROSA, which is the Recovery Oriented Services Assessment, which was designed with people with lived experience. It was designed by some folks that are near and dear to our hearts, the folks at 𝐏𝐼𝐸, and it was designed to do to assess specifically. There's an assessment for the person, the individual to do, and then one for the organization to do. And we're going to take a look at it, and you'll see that it's geared, it really lends itself well to peer-run programs. And then there's the recovery capital assessments, there's the World Health, so these are possible ways to address this issue. They're all assessments, it's still assessments, but some of these were designed specifically for people being people and not clinical settings. The ROSA is that. The recovery capital, not so much. But it begins to at least be strengths based instead of, and y'all have a lot more experience with it than I do. The literature, all the literature I found on assessments is mixed bag on whether or not they do what they say they're going to do. The psychometrics, which is the data about the data, do they have fidelity, is a mixed bag. And most of them at some point in the assessment of the assessments will tell you they don't measure recovery, because we measure all around it, but they have the same problem we do. How do you measure recovery? So the recovery capital is kind of like that. They're measuring what's out in the environment for the person, but not their own personal recovery. The World Health Organization has the quality of life assessment. There's a very extensive one, and then there's the brief one, and then also there's several different instruments that can be used to measure well-being, which is what we tend to lean towards on the mental health side, and then measuring resilience. And there's a lot of material on resilience on kids. I saw that Stormy came in. The one I looked at was the family resilience. And so to address some of the family partner concerns, but there's different ones on resilience that can be used. The kicker is some of these you can't get unless you're doing a clinical research, which is, by definition, not peer. So these are some of the challenges in us using established instruments. All right, the ROSA. So unless you have the world's greatest eyesight, that may not work for you. So let me bring up the ROSA for us to look at. And it looks a lot like
Thank you for doing that, Anna. I was already like, oh, good Lord, I can't even see that.
Yeah, no, there was no way. Aha, there, is that better? Okay, so this is from the article that was released about the ROSA. You might recognize Amy Lodge works for 𝐏𝐼𝐸. Julie Early, I think I've heard her name. Mansour sounds familiar. These should be names that we recognize and know. So Julie was definitely part of this and developed the ROSA for us to use. Let me see if I can. All right, that's not going to do what I want it to do. All right, so it's on a scale of never to always. And this is the assessment for staff. So it's what your organization would use about your own approaches to supporting people. And so you answer, our organization asks people about their interests, supports people to develop plans for their future, invites people to include those who are important to them in their planning. And you can see that these are things that align with peer support and align with person-driven approaches. Does the organization offer support services that support people's culture or life experience? And if you're not answering these, this can also serve as an organizational self-assessment in terms of, are you meeting some of these values of peer support? Introduces people to peer support or advocacy. Again, it's not specifically for peer-run organizations, but definitely serves peer-run organizations. Encourages people to take risks, to try new things, models hope, focuses on partnering with people to meet their goals, respects people's decision about their lives, partners with people to discuss progress towards their goals, etc., etc., etc. And then you have the scoring mechanism. So this is the one. So that was the one for the organization. This is the one for the participants in the program, right? So this organization, you can put in your name there, and this is the people that come and you walk with them on their recovery journey, and they get to fill this out about your organization. Asks me about my interests, supports me to develop plans for my future. So you see it maps it, but now from a personal perspective. Focuses, I'm jumping down, focuses on partnering with me to meet my goals, respects my decisions about my life, partners with me to discuss progress towards my goals, offers me a choice of services to support my goals, offers me opportunities to discuss my spiritual needs when I wish. That one for the mental health peer-run programs is we tend to all score pretty high. The lowest thing we score on is the spiritual aspect, which is a reoccurring theme in some of these assessments is that component tends to get left out. And it is a challenge if you're trying to be all inclusive of all faiths and belief systems while still honoring the individual. So it may show up more in individual settings where you're actually wanting to know more about their faith and spiritual beliefs than it may in a group setting, where you're wanting to make sure that it's equal for everybody. So that's one of the things that I know Prosumers has been working on. Believes I can grow and recover, is open with me about all matters regarding my services. One of the values under the National Practice Guidelines is that peers are open and honest, and we don't sugarcoat. We make sure people know what's so, right? And we provide trauma-specific services. So this is the ROSA. We have used it at Prosumers. It is effective and in bringing up areas where we may have gaps, as well as it has an opportunity. You can put in an opportunity for people to share more, and they and you get some of that qualitative work as well. So that's one possible survey that can be used. The other survey that was mentioned in the when we were collecting from your knowledge base is the Prios. It is also developed by TimeH, and we are currently using it. It gives a little more information. I'm not going to go into it, so because I want to make sure that we have a chance to review some of these others. Angelina, you have a question?
Yes. So my question is, so anyone can use this? Like anyone can use it in their organization?
The ROSA? It's my understanding that anyone can use it. And I will defer to Julie on that. Julie, do you mind jumping in on that? Are you
Julie
still
had
here?
to step out, but we can definitely just double check with her and make sure that there's a follow-up about it.
Okay.
I think it would be available to anyone who would want to use it.
Okay.
It should be, from my conversations with them. It was developed for peer-run organizations, specifically for peer supporters, from my understanding. So,
Yeah. I'm very interested in using that within our organization, just because it has some of the different questions than some of the surveys that we take, like with our work with the peer support, and then also with the people that we serve. So I kind of like this questionnaire. It's like nice and clean and short and to the point. So that's why I was asking if anyone could use it. So yeah, thank you.
Yeah, absolutely. It is effective, and it's great if we can start adopting our own that we want to use. And this one was developed by people with lived experience. Prosumers was part of that process. So, is there a link? So what there is I need to put a bunch of documents in for this for y'all, and I will do that in a little bit, and you could hopefully you'll be able to download it from the chat. And what it is so what I have is the article stating how it got developed. So there's a lot of information to share with y'all. It is very standard research heavy. I would encourage you as developing leaders in our field that you get used to reading research. And the only way to get used to reading research is to read it. And it is a pain initially. Because if you don't know statistics, the tables make no sense. But if you read the narrative, there comes a point in time when you're like, oh, that's what they're talking about. And the more you read them, the more you get used to it, and the more you begin to understand the work. And we can discuss it. Having discussion groups on what we're reading can make a difference. So I would be surprised if there aren't some people in this group who have some narrative in their head that they don't have enough education, so they can't make sense out of those things. I invite you to just know that is an old tape and it isn't true. You guys have risen to the point of leadership. You've been acknowledged for your leadership, your creativity, and your brains. So even if it doesn't make sense, keep reading it. Eventually it will make sense. It's not because you can't learn, it's because you haven't been exposed to it. Right? So I encourage you to let go of that narrative. So just so y'all know, okay? And thank you, Jesse, for putting in the chat about the amazing researchers we have who are really representing our voice in their work. And anything by the people that you put on there are worth checking out. All right, so moving right along. So far so good. Any questions? So next, and this one I'm really going to depend on you guys to support me in some of this, because y'all know this more than I do. But this is in terms of how we, the whole recovery capital assessment. This is drawn from a report that was based on some research done when SAMHSA was trying to find something to measure recovery with. And this was an interesting comment on recovery capital assessments. And basically it says, that the instrument contains 23 items, measures 8 domains: resilience, reliance on religion, spirituality, recent sobriety, stable income, alcohol, drug-free environment, percentage of lifetime spent free from the effects of substance use, satisfaction with living situation, amount of education and training. And the author notes that recovery capital is an important concept, but the instrument measures aspects of what is needed to achieve recovery, not recovery itself. So that again is one of the challenges that we face in trying to address some of these things. But one of the instruments that is used in recovery capital is the multidimensional inventory of recovery capital. Chris, is this the one that you use? You had mentioned that y'all assess recovery capital. Okay, I think he's busy. So we're gonna move on. All right. Can everybody see this? It talks about social capital. It's on a 4-point Likert scale. I actively support other people who are in recovery. My family makes my recovery more difficult, and you get a sense of some of the social some capital, and capital being like your strengths that the person has. You have physical capital. My housing situation is helpful for my recovery. I have difficulty getting transportation. My housing situation is unstable. I have enough money every week to buy the basics. So you see how it is measuring what's in the environment. Human capital. One of the things that we lose in our worlds that we navigate is the ability to have fun. When you are in survival mode most of the time, fun, happiness, none of that has any survival value, or at least we don't think it does. So we tend not to allow those experiences in our life because we're busy, either finding our next fix, our next food, our next shelter, whatever it is that we see as survival, right? So this is what do you have within yourself to keep you going? I feel physically healthy. I'm struggling with guilt and shame. I'm experiencing a lot of stress. My education and training have prepared me to handle life's challenges, etc. So this again is what are you bringing to the table? And it's based on what has been seen as being supportive of recovery, but it's not measuring recovery. Cultural capital, it's hard for me to trust others. I have opportunities to participate in fun activities. I feel like an outcast. There are helpful services and resources accessible to me. One of the challenges with this is we begin to raise awareness about culture and the importance of culture, and the idea that othering is on the rise is you may not fully understand what the answer to some of these questions means to the person you're asking it of. Is feeling like an outcast due to my culture, due to my language, due to my love preference? Or is it due to, my using, or is it due to my mental health issues being out of exhibiting themselves so much? So it's hard to really determine what it is. And then you have the scoring instructions. But this is another one that you can that you can use. Again, it measures the environment that we're in. All right. So I'm gonna step it up here. Let me just keep sharing instead of going back to the slides. Here's the World Health Organization Quality of Life Assessment. It provides a space for some demographics. This is the short version. The other one has like a cajillion items. It's again on a Likert scale, 1 being not at all, 5 being completely. And it's tied to, again, environment. And quality of life tends to focus a lot on social determinants of health. And this one was designed by the Behavioral Health Unit of the World Health Organization. And this one tends to get used a lot even when new ones are developed. And this one was developed in 2012, I believe. Do you get the kind of support from others that you need? How would you rate your quality of life? It's, straightforward. What do you think? How satisfied are you with your health? To what extent do you feel that physical pain prevents you from doing what you need to do? So it addresses some of the things that may be barriers, but it's not tied specifically to substance use or mental health. How much do you need any medical treatment to function in your daily life? How much do you enjoy life? And so forth and so on. This is a good one to be able to show quality of life over time. One of the challenge with most of these assessments is that they either, when people fill them out, depending on where they are, they maximize it on the lower end, or they maximize it on the top end. One of the things that happens for us is that we serve people who are in recovery. We walk with them on their recovery journey. And there comes a point in time when what we're measuring, what a lot of these measure is, are you actively in your challenges, or are you doing well? But they don't have the nuance to show improvement over time, especially at the top end of things. So some of these instruments kind of max out and don't tell you good information. So that's the other thing that we need to be looking at, is developing things that actually show progress over time. And just how much I like my life isn't progress over time, because I may not, life will life us. What we might want to measure is, do I believe I have what I need to get through this? And there's a scale that I didn't use here because you have to say you're a researcher to get a copy of it, but it's the sense of coherence scale. It's a resiliency scale. And I would love for us to be able to get that and look at it. It's a scale that was at one time used at NASA to screen for applicants who wanted to be astronauts, because it really does point towards, do you see yourself as someone who can face life? And so in that sense, it's a great resilience tool. Anyway, so this is the quality of life. Here's this one. This is an article on the measurement of properties of family resiliency assessment questionnaire. I wasn't able to get a copy of the questionnaire. Again, it has a bias based on clinical approaches. So I will share these with you. There are multiple things out there that we can use, and it's up to us to have some discretion about it. So these are the ones that I then showed you so that you could see them. Well-being objective is often assessed using indicators that measure aspects of the social determinants of health, not well-being. Because there's a whole area of knowledge and research on well-being. It does tend to capture societal rather than individual perspectives on well-being. So those are the challenges with those. And with resilience, there's challenges with those. One other thing I did want to share with y'all is a book. Let's see if I can get to it. For those of you who like books, there is a interesting book on the measurement of well-being that looks a lot like this. and it's a collection of articles, and it gives you some philosophical ideas, as well as the challenges and considerations to have when you are looking at measuring well-being. So if this is something that you really want to take a deep dive into, this is the Kindle version. I got it on Amazon. They do have the hardback is like 34 something. This was 28 something. But it's let me see if I can get to the empirical research and reflections on well-being measurement is one of the sections. Part 2 is conceptual reflections on well-being measurement. And it looks at how part of the problem with well-being is that how do we measure, it talks about, is it that we are constantly having fun? Is it the absence of suffering? Is it contentment? So these are some of the challenges. Advancing the conversation about measurement. How do you measure it? So this is a resource if it's something that you really want to look at. Some of the thinking that you might want to do in choosing a way of measuring well-being and these issues that we're looking at. One of the things in terms of measuring is if we're measuring happiness, the research on happiness shows that it is a very fleeting, it's very subjective and it's very fleeting, because when people reach a certain level of happiness, even if that becomes their new normal, they're no longer, there comes a point in time when they're not happy, because we always see that as something that I haven't achieved yet. And research on like people who win the lottery, people who think they're now happy because they can do what they want to do, have what they want. That elation, that experience lasts for about a year. And then that's the new normal, and they're just back to being normal, right? So these are some of the challenges in measuring happiness. So questions, thoughts, comments? I left you a grand total of whopping 6 minutes here.
Well, first I want to say thank you, Anna, and I don't want to take everybody's time for questions or comments, but this is something that's really relevant in time as well. I was last month, I believe, able to attend a meeting called the 𝐿SMIC meeting, which stands for a bunch of letters. But essentially it's a federal meeting, and I wasn't a part of it, I was just listening in, but they help to provide direction, suggestions to essentially all of the federal departments in government. So like Social Security receives their reports, as well as SAMHSA, as well as all these other folks, right? And one of their big goals, like over the next 6 months to year that they said, is looking at recovery-based measures and making sure that we're looking at care based on recovery-based measures. Measurement-based care is what they specifically said. And I know that SAMHSA has been looking at recovery-based measures, and what are they, right? Because there's all of these clinical things. What are the recovery-based ones? And so if we're federally, they're looking at measurement-based care, we need to make sure that we're having these conversations about how to look at recovery-based measures in a peer-centered way so that we're not left out of the conversation.
Right.
Mm-hmm. And it isn't a given that we won't be left out of the conversation. Just a thought.
Absolutely true.
I know we've been talking about on an organizational scale in measuring data, and I put it in the chat, but on a more one-to-one basis, I really like talking to peers about recovery capital. A lot of peers that I work with, they don't like recognize those things, and it's a good tool to help them realize maybe the wholeness, the fullness of the recovery, like what is really going on. You know, I have a lot that don't like the 12-step time model. But for some reason I needed to say that to one peer a while back, and now it's just in my toolkit. But it also helps with when I need to do an assessment. By the way, it's like a terrific segue, you know, and so that they can get something out of it too.
Makes sense. I am putting some things in. So I will send a whole list of things to be uploaded or to be sent out to y'all. One is the manual on using the World Health Organization instrument, and it's a manual, so it won't upload to the chat. But I will get these to you. Y'all can jump in at whatever level you want. Again, Stormy, most of the work with families is around resilience. Something to maybe explore and consider for you.
Thank you.
Yeah, absolutely. And yeah, this is a growing field. There's more instruments out there than you can shake a stick at. Some cost money. Some don't. Ultimately, it's, do people reflect that? So I say that we get to measure our services in 2 or 3 ways. One is, do they keep coming? They must be getting something out of it. 2, do they quit coming because they're too busy living their life? I can't tell you how many people say that, well, that they stop coming to the prosumer meetings because they got a job and they can't come at those hours because they're living their life. And 3 is, we miss the boat. So how do we, how do we find those things in a way that we can show where we need growth ourselves as organizations, as well as how do we share with the world the impact we have, which is something that will be coming up in the July meeting. So any other comments, questions, thoughts?
Well, thank you, Anna. This has been wonderful. I would encourage you all to see, now that you've had this conversation from Anna in 101 and 201, to take this information back and see what is your organization doing. I know we talked about that at the beginning, but go back and ask the questions and look at it with fresh eyes after having these conversations. Look at what the surveys that you're giving to folks. Do these feel like questions that you would want to answer? How are we using this information and how are we communicating this information, right?
I really encourage y'all to look and see, what are you willing to do? What does fidelity mean to you? What are you going to true yourself up to? And how are you going to show you're doing what you're doing? And one of the things that we didn't even touch on is town hall meetings, is in-person conversations, is qualitative review of interviews, and satisfaction surveys. Asking people, how am I doing? What do you think about what we're doing? Having those broader, open-ended types of interactions with the people that we have the privilege of walking with. So those are also excellent ways of finding out, are you doing what you want to do? And there are ways of turning those into reportable data through word, through word assessments, and just there's qualitative data analysis that can be done on interviews and things like that. So that's another approach. It's more time consuming. To me, it gives us more of what the richness of what we actually accomplish.